Welcome to the Deep Dive, where we take complex topics and give you the fast track to understanding them. Today, we're plunging into the incredible world of the human body. It's just this masterpiece of complexity and resilience, constantly striving for balance and defending itself against, well, everything. In this deep dive, we're going to take a really comprehensive look at how our bodies keep that equilibrium, what happens when that delicate balance gets disrupted,
Right.
how medical interventions step in to support these vital systems, and the crucial, often invisible ways our bodies defend themselves. Our source material for this is, well, it's this really comprehensive blueprint. It covers everything, from the tiniest shifts in electrolytes
hmm
all the way to major surgical considerations and the body's incredibly intricate defense mechanisms. It's quite something.
And our mission for you today is basically to provide that shortcut to understanding these vital concepts.
Yeah.
We'll offer clarity, highlight those key insights, and hopefully deliver plenty of those aha moments that make complex medical info not just accessible, but really truly grasped.
Okay, let's unpack this then. At the very, very foundation of our body's health is this delicate balance, especially when we talk about fluids and those tiny but mighty things called electrolytes, like sodium, for instance.
Dave.
It's crucial, right, for regulating fluid volume and how our nerves and muscles actually function.
And what's truly remarkable here, I think, is how interconnected these electrolytes are. They don't work in isolation. For example, magnesium. It's actually crucial for the body to hold on to potassium.
Oh, interesting.
Yeah, and calcium and magnesium, they work kind of hand in hand in neuromuscular function. It's a really complex, precisely choreographed dance of chemical relationships.
It really is. So when sodium levels get too low, that's hyponatremia, it's often because there's just too much water compared to the salt.
Right, diluted.
Exactly. Common causes could be certain diuretics, maybe drinking excessive amounts of water, or conditions like SIADH.
Yeah, syndrome of inappropriate antidiuretic hormone. Basically, your body holds on to too much water.
Got it. And symptom-wise, you might see confusion, headaches, maybe even seizures, muscle weakness. For mild cases, just restricting fluids might do it, but severe situations can be life-threatening. They might need concentrated saline solutions and definitely seizure precautions. Then on the flip side, you've got hypernatremia, too much sodium. That usually points towards dehydration, meaning not enough water in the body.
Less water, more salt concentration.
Precisely. You might see this with conditions like diabetes insipidus or a high fever, severe burns. The body tries to tell you, right? Intense thirst, dry mouth, restlessness, irritability.
Yeah, those classic signs.
So interventions here focus on carefully rehydrating, usually with fluids that pull water back into the cells, like 0.45% normal saline, half normal saline.
Carefully is the key word there, to avoid complications like cerebral edema. Next up, potassium, symbol K. This one is absolutely vital for cardiac and muscle function. That's why we often say K equals heart stuff.
Right, heart stuff, good mnemonic.
When potassium levels dip too low, hypokalemia, it's often due to fluid loss. Think diuretics again, vomiting, diarrhea. You literally lose potassium through your gut.
Makes sense.
Symptoms can include muscle weakness, fatigue, and concerningly, those irregular heart rhythms, arrhythmias.
And a really critical safety point here. You can never give potassium as an IV push. Absolutely not. It has to be diluted and infused slowly or given orally.
Crucial point.
And we also encourage foods rich in potassium, bananas, potatoes, spinach, that kind of thing.
Conversely, hyperkalemia, too much potassium, is often seen when the body can't get rid of potassium properly. Think kidney failure, or after extensive burns or trauma where cells break down and release potassium.
Okay.
This can lead to distinctive changes on an ECG, like those tall peak T waves, a slow heart rate, bradycardia, and muscle weakness. Treatments can range from medications like Kyaxalate, which binds potassium in the gut, to things like insulin and glucose infusions, which drive potassium back into cells, or even dialysis if it's really severe. Cardiac monitoring is essential.
Moving on to calcium. Kawa. Essential for muscle contractions, blood clotting, keeping bones strong. It works closely with others too, directly related to magnesium, inversely related to phosphorus.
That interplay is key.
Definitely. When calcium is too low, hypocalcemia, you might see muscle cramps and tetany, that involuntary muscle contraction.
Yeah.
And those classic signs like Schwastek's sign.
The facial twitch when you tap the nerve.
Yeah, that one. Or Trousseau's sign, the hand spasm with the blood pressure cuff.
Right. And when calcium's too high, hypercalcemia often seen with things like overactive parathyroid glands, certain cancers, or even just prolonged immobility.
Immobility, really?
Yeah, being stuck in bed for too long can actually cause calcium to leach out of the bones. Symptoms might be more generalized weakness, lethargy, feeling sluggish, and a higher risk for kidney stones.
Wow, okay. Immobility causing high calcium and kidney stones. That's a good nugget.
And constipation, decreased reflexes too.
Finally, magnesium, MgU. This one really impacts our reflexes. If levels are too low, hypomagnesemia often linked to chronic alcoholism, maybe long-term use of proton pump inhibitors, or severe GI losses.
Diarrhea or NG suction.
Exactly. You'll see things like tremors, tetany again, maybe seizures, and importantly, very active deep tendon reflexes, like the knee jerk is way more pronounced.
Hyperreflexia, yeah.
Yeah.
But if there's too much magnesium, hypermagnesemia, perhaps from kidney failure, or just taking way too many magnesium-containing antacids or laxatives.
Oh, right, like milk of magnesia.
Exactly. Then you observe the opposite. Profound lethargy, muscle weakness, flushing, low blood pressure, slow heart rate, and a distinct decrease in deep tendon reflexes.
Yeah.
Sometimes they're even absent. That difference in reflex activity is a really crucial diagnostic clue.
So helpful in HYPO hyperreflexes and hypo or absent reflexes.
Look at them.
So beyond these individual electrolytes, the body also struggles with overall fluid volume. Hypovolemia, that's a fluid volume deficit. Literally too little fluid circulating, caused by things like hemorrhage, severe diarrhea, extensive burns.
Significant fluid loss.
Yeah, you'll see the body trying to compensate, right? Fast heart rate, low blood pressure, dry mucous membranes, maybe poor skin turgor where the skin doesn't snap back quickly,
Yeah.
and decreased urine output.
Oliguria.
Right. The main intervention is just getting fluids back in, usually with isotonic solutions like 4.9% normal saline or lactated ringers.
Then there's the opposite problem. Hypervolemia. Fluid volume excess.
Yeah.
Too much fluid. This can happen with conditions like congestive heart failure, kidney failure, or even just getting too much IV fluid too quickly.
CLOV overload.
Exactly.
Yeah.
You'll often see visible swelling, edema, maybe distended neck veins, JVD, a bounding pulse, and those telltale crackling sounds in the lungs, pulmonary crackles from fluid buildup. Diuretics are usually the key here to help the body get rid of that excess fluid, and sodium restriction, of course.
It's definitely worth noting that age plays a big role here. Infants and kids, they have a higher percentage of total body water, so they can get dehydrated much faster.
Very vulnerable.
And older adults, on the other hand, often have a weaker thirst mechanism, maybe decreased kidney function. So they're at risk for both dehydration and fluid overload, especially if they have heart issues or are on diuretics.
It's a double-edged sword for them sometimes.
Yeah. And when we talk about fluid loss, there are two types. Sensible losses, things we can measure, like urine, feces, vomit.
Right. Output.
And insensible losses, which aren't easily measured, like fluid loss just through sweating or breathing.
Evaporation from skin and lungs.
Exactly. The most accurate way to track overall fluid balance day to day, daily weights. A change of 1 kilogram in weight usually equals about 1 liter of fluid gained or lost.
That's the gold standard for fluid status. Physiologically, when someone's dehydrated, their plasma volume shrinks, which leads to lower blood pressure. The heart rate increases to compensate.
Tachycardia.
Right. The blood also gets more concentrated. So you might see labs like hematocrit or BUN go up. Clinically, you'll notice that decreased skin turgor, dry mucous membranes, and urine output drops, becoming dark and concentrated.
Okay, here's where it gets, I think, really interesting. Beyond just fluids and electrolytes, the body has this incredibly tight control over its pH balance, acid-base balance. Even tiny deviations here can have huge effects system-wide.
Absolutely. And the fundamental question is why? Why is maintaining this incredibly narrow pH range, typically 7.35 to 7.45, so critical?
Yeah, why?
Because even minor shifts can totally disrupt enzyme function, cellular processes. Literally everything from your heart rhythm to your neurological function depends on it. It's a cornerstone of cellular life and overall health.
Wow. Okay, so when we talk about acid-base balance, we often look at arterial blood gases, ABGs. We look at the pH itself, the PACOs, which reflects the respiratory component, how much carbon dioxide is in the blood.
Controlled by breathing.
Right. And HCOO, bicarbonate, which is the metabolic component, mainly managed by the kidneys.
And the body has these amazing ways to compensate if things go off kilter. If the pH is abnormal, and only one of those components, either CO or H2O, is also abnormal, it means the body hasn't really started compensating yet.
Okay, no compensation.
But if the pH is still abnormal, and both the KO and the HCO are abnormal, that tells you the body is trying hard to correct the imbalance. It's partially compensating, but hasn't quite fixed the pH yet. Everything's out of whack.
Partial compensation, everything abnormal, got it.
And then if the pH has actually returned to the normal range, but both KOO and HCO are still abnormal, that means full compensation has occurred. The body successfully buffered the pH back to normal, even though the underlying problem is still there.
Okay, that makes sense. The pH is fixed, but the other numbers show the struggle.
Exactly. Now, when you have too much acidosis, it can be either respiratory or metabolic. Respiratory acidosis comes from hypoventilation. Basically, anything preventing you from breathing off enough KORs.
Like COPD, or maybe being oversedated with opioids, or having an airway obstruction.
Right, the body isn't getting rid of KORs, so acid builds up. This leads to symptoms like confusion, drowsiness, headache, shallow breathing, maybe even cyanosis, the bluish tint to the skin.
Okay. And metabolic acidosis.
That stems from other issues like diabetic ketoacidosis, DKA, kidney failure, severe diarrhea, losing base, shock, lactic acidosis from poor tissue oxygenation, sepsis, even a late aspirin overdose.
Wow, lots of causes.
Yeah, and a classic sign you might see here is Kussmaul respirations, those deep, rapid breaths. It's the body's desperate attempt to blow off Kussmaul to counteract the metabolic acid. Also fatigue, nausea, confusion.
Kussmaul respirations for metabolic acidosis. Good visual.
Then for alkalosis, too much base or too little acid respiratory alkalosis is typically caused by hyperventilation, breathing too fast.
Like from anxiety, severe pain, maybe high altitude, or even early aspirin toxicity.
Exactly. You're blowing off too much CoAero, making the blood too alkaline. Symptoms: dizziness, lightheadedness, tingling or numbness, muscle cramps, fast breathing.
Okay, and metabolic alkalosis.
That happens when acid is leaving the body too quickly. Think prolonged vomiting, continuous NG suctioning, pulling out stomach acid, taking way too many antacids, or even certain diuretics that cause potassium loss, which is linked to alkalosis.
So acid is leaving too quickly?
Right. Symptoms here can include muscle cramps, tingling again, irritability, maybe confusion, and interestingly, slow, shallow breathing as the body tries to retain COO to balance out the excess base.
Fascinating how the body tries to compensate. Okay, so now that we've talked about what the body needs to keep in balance, sometimes it needs a little help, right? Or a very specific type of support. That's where infusion therapy comes in. IV fluids. We generally put them into two big categories: crystalloids and colloids.
Right. Crystalloids are those clear solutions, small molecules that can easily pass through semi-permeable membranes like capillary walls. We further divide them based on their tonicity compared to blood plasma.
Tonicity, okay.
Isotonic solutions like 0.9% normal saline or lactated ringers, LR, have about the same concentration as blood. They're great for expanding the intravascular volume, the fluid within the blood vessels, without causing major fluid shifts between compartments.
So good for dehydration, shock, blood loss, burns.
Exactly. Just need to watch for fluid overload, especially in patients with heart failure or kidney issues. And a key point for you, LR contains potassium, so you generally avoid it in patients with kidney failure or high potassium levels.
Good tip. LR has K. Avoid in renal failure. Got it. What about hypotonic?
Hypotonic solutions like 0.45% NS, half normal saline, or D5W once the dextrose is metabolized, have a lower concentration than blood. They cause fluid to shift out of the bloodstream and into the cells and interstitial space.
So they hydrate the cells themselves.
Precisely. Useful in conditions like DKA after initial stabilization or hypernatremia, where cells are dehydrated. But you have to be cautious. They can cause cells to swell, particularly brain cells, leading to cerebral edema. So definitely avoid it in patients with increased intracranial pressure, trauma, burns, or liver disease. And you monitor for signs of low blood volume hypotension.
Right, because the fluid is leaving the vessels, than hypertonic solutions.
These have a higher concentration than blood, things like 3% or 5% saline, D10W, D5NS, TPN. They do the opposite. They pull fluid out of the cells and interstitial space into the bloodstream.
So they shrink cells and expand blood volume.
Exactly. Used for severe hyponatremia or to reduce cerebral edema. But they are potent. They usually need to be given via a central line, especially if it's over 10% dextrose or highly concentrated saline, and you have to monitor very closely for fluid overload and pulmonary edema. Use extreme caution in heart or kidney failure patients.
Okay, crystalloids covered. What about colloids?
Colloids are different. They contain large molecules like proteins or starches that don't easily pass through those semi-permeable membranes. So they tend to stay within the intravascular space and pull fluid into the vessels.
Ah, like plasma expanders.
Exactly. Examples include blood components like red blood cells or platelets, albumin, and plasma itself.
Gotcha. So to get these fluids into the body, we need vascular access. Let's talk devices. Peripheral IVs, PIVs, those are common.
Very common. Used for short-term therapy, usually just 3 to 4 days. Good for basic fluid administration, medications. Site care is crucial, though. Assessing the site regularly, like every 4 hours, treating the site every 72, 96 hours per protocol, and always using aseptic technique.
To prevent complications, right, like phlebitis.
Right. Phlebitis, inflammation of the vein, looks red, feels warm, tender along the vein. Or infiltration, where the IV fluid leaks into the surrounding tissue instead of the vein. That area usually looks cool, swollen, maybe pale, but often not painful initially.
And extravasation. That sounds worse.
It is worse. That's when a vesicant, a medication that can damage tissue, infiltrates. That can cause serious tissue injury or necrosis. And of course, infection is always a risk at any IV site.
Okay. What about midline catheters?
Midlines offer sort of intermediate access, maybe for 1 to 4 weeks. Good for things like longer courses of antibiotics or hydration. They're inserted in the upper arm into a larger peripheral vein, but the tip doesn't go into the central circulation like a central line.
So still peripheral access, just longer and deeper.
Essentially, yes.
Yeah.
But a key limitation: you cannot infuse vesicants or TPN through a midline. It's not designed for those highly irritating or concentrated solutions.
Good distinction. For longer term or more specialized stuff, we need central venous access devices, CV-aids, like PICC lines, tunneled catheters, implanted ports.
Right. These lines terminate in a large central vein, usually the superior vena cava right near the heart. Maintaining them requires strict sterile technique for dressing changes, cap changes usually weekly or per protocol. You flush them regularly, usually with saline, sometimes heparin, depending on the type and protocol. And critically, you must scrub the access port vigorously for at least 15, maybe 30 seconds before connecting anything.
Scrub the hub, 15 seconds minimum. Got it. What are the big risks with central lines?
Infection is a major one, specifically catheter-related bloodstream infection, or CRBSI. Prevention is key. Meticulous hand hygiene, full barrier precautions during insertion, using chlorhexidine for skin prep, and removing the catheter as soon as it's no longer needed.
Makes sense. Other complications?
Occlusion, the line gets blocked. Could be a kink or a clot. You check for kinks, maybe reposition the patient. Sometimes a thrombolytic drug like alteplase might be needed to dissolve a clot. Then there's the risk of an air embolism if air gets into the line.
You mentioned that clamp the catheter, left Trendelenburg, give oxygen.
Exactly. That position helps trap air in the right ventricle. Catheter migration or breakage can also happen. And a huge safety point: placement must be confirmed by chest x-ray before you use the line for the first time. The tip needs to be in the right spot, usually the lower SV right atrium junction. No infusions until that confirmation.
Okay, X-ray confirmation is non-negotiable. So if we connect this to the bigger picture, vascular access isn't just about fluids, is it?
Not at all. It's a critical gateway. Life-saving medications, nutrition like TPN, blood products, even diagnostics like central venous pressure monitoring. But because it bypasses many of the body's natural defenses, it comes with significant risks if not managed meticulously. It really highlights why those strict aseptic techniques are absolutely paramount.
Yeah, that makes total sense. Okay, speaking of interventions, let's shift gears and talk about something many of us will face at some point: surgery. Perioperative care. There's just this whole world of meticulous planning and care wrapped around that single event.
Absolutely. It starts well before the operating room with preoperative care. Patient safety is number one. Using 2 patient identifiers like name and date of birth every single time. Ensuring the surgeon marks the correct surgical site, ideally with the patient awake and participating.
Right, site marking. And NPO status.
Crucial. Nothing by mouth, usually for 6 to 8 hours before surgery, depending on the procedure and anesthesia. This prevents aspiration stomach contents getting into the lungs during anesthesia. And importantly, education happens before surgery.
Post-op teaching before surgery seems counterintuitive.
It makes sense when you think about it. Patients are more alert and receptive before anesthesia and pain meds. So you explain the procedure, what to expect, how recovery will go. You teach them things like deep breathing, coughing, using an incentive spirometer to keep their lungs clear.
Prevent pneumonia and atelectasis later.
Exactly. Teach leg exercises or the importance of early ambulation to prevent blood clots. Explain any equipment they might wake up with, like drains or monitors, and discuss pain management expectations. Also, practical things. Remove jewelry, dentures, contacts, even nail polish or makeup.
Got it. What about informed consent?
That's obtained by the surgeon. They explain the procedure, risks, benefits, alternatives, and the patient's right to refuse. The nurse's role is typically to witness the patient's signature, confirm they understand, and maybe clarify information, but not to provide the primary explanation of the procedure itself. And the patient absolutely must be mentally competent, alert, and not under the influence of sedating medications when they sign.
Okay, surgeon explains, nurse witnesses, patient must be competent. What about medications on the day of surgery? Do people stop everything?
Not always. Some medications are often continued, but always verify with the provider. Beta blockers, for instance, might be continued to prevent cardiac events during the stress of surgery. Insulin doses might be adjusted. Anticonvulsants are usually continued. Steroids might be given to prevent adrenal insufficiency if the patient takes them regularly. Even things like inhalers or glaucoma eye drops are often continued.
Interesting, so it's very specific.
Very. And common pre-op meds given right before surgery often include antibiotics, like cefazolin, usually within an hour before the incision to prevent infection. Maybe an anxiolytic to reduce anxiety, an antiemetic for nausea, or drugs to reduce stomach acid.
Okay, that covers pre-op. What about immediately after surgery? Post-op care.
Post-op is all about immediate safety and assessment, starting with the ABCs. Airway is a clear. Breathing rate, depth, oxygen saturation, circulation, blood pressure, heart rate, skin color, capillary refill, checking for bleeding.
Yeah.
Those are the absolute priorities.
ABCs first, always.
Yeah.
What else?
Neurological status, level of consciousness, orientation, pain control, assessing pain using a scale, giving medication, and reassessing its effectiveness. Checking the surgical site, looking at the dressing, any drainage, signs of bleeding. Monitoring urine output, we expect at least 30 millimolars per hour as a sign of adequate kidney perfusion. And checking IV lines and drains for patency and output.
Okay, thorough assessment. You mentioned malignant hyperthermia earlier.
Yes, MH. It's a rare but potentially fatal inherited muscle disorder triggered by certain anesthesia drugs. The signs are dramatic: muscle rigidity, a rapid rise in body temperature, increased calcium and potassium levels, metabolic acidosis, and dangerous cardiac dysrhythmias. Recognizing this early and alerting the surgeon and anesthesia provider immediately is critical. There's a specific antidote, dantrolene.
Good to know. And preventing common post-op complications, like lung issues.
For atelectasis and pneumonia, the mantra is turn, cough, deep breathe, and mobilize early. Get the patient moving as soon as safely possible. Use that incentive spirometer.
And blood clots, DVT-PE.
Compression devices on the legs, early ambulation again, and sometimes anticoagulant medications.
What about paralytic ileus when the bowels slow down?
Right. Keep the patient NPO until bowel sounds return and they're passing gas. Ambulation helps stimulate the bowels. Sometimes an NG tube might be needed to decompress the stomach if it gets bad.
Okay. And the timeout.
The timeout, or universal protocol, is a critical safety check done immediately before the surgical incision. The entire team pauses to confirm. Correct patient identity, correct procedure, correct side and site. Everyone agrees on what's being done. Are any necessary implants or special equipment available? Is the patient positioned correctly? It's designed to prevent wrong site, wrong procedure, wrong patient errors.
Seems simple, but so important.
Incredibly important. So this really raises the question, how does all this meticulous perioperative planning actually translate into better patient outcome?
Yeah, what's the impact?
It's fundamentally the difference between a controlled, predictable recovery and potentially life-threatening complications. Every step, from pre-op teaching to the timeout to vigilant post-op monitoring, is designed to anticipate risks and intervene early. The timeout, for example, is a seemingly simple step, but it's incredibly powerful in preventing absolutely devastating errors.
It really puts it in perspective. Okay, our bodies are amazing at balance, but they're also constantly under siege from outside invaders, right? Which brings us to infection control and our incredible immune system.
Exactly. Infection control starts with the basics, standard precautions. These apply to all patients, regardless of their diagnosis. It's things like rigorous hand hygiene before and after any patient contact, using gloves when touching potentially infectious material, wearing other PPE like gowns or masks as needed based on the task, proper handling of sharps and contaminated items, and respiratory hygiene or cough etiquette.
Standard precautions for everyone. Then we add more if needed.
Right. That's where transmission-based precautions come in, based on how a specific pathogen spreads. For bugs spread by direct or indirect contact, like MRSA or C. diff, we use contact precautions. Gown and gloves are essential. For MRSA, maybe dedicated equipment stays in the room.
And C. diff, you mentioned something specific.
Yes, C. diff forms spores, which are really hardy. Alcohol-based hand gels don't kill spores effectively. So for C. diff, you must wash hands with soap and water. And environmental cleaning requires bleach-based disinfectants.
Hmm.
Transmission is fecal-oral, so meticulous hygiene is key.
Soap and water and bleach for C. diff. Got it. What about droplet precautions?
Used for pathogens spread through larger respiratory droplets like influenza or standard COVID-19 transmission during routine care. These droplets typically travel only short distances, maybe 6 feet. So wearing a surgical mask when within that distance is the main requirement.
And airborne.
Airborne precautions are for pathogens spread via smaller droplet nuclei that can remain suspended in the air and travel longer distances. Think tuberculosis, TB, or COVID-19 during aerosol-generating procedures. This requires wearing an N95 respirator mask, which filters smaller particles, and placing the patient in a negative pressure room to prevent air from escaping. If the patient has to leave the room, they wear a surgical mask.
N95 and negative pressure for airborne. So what's fascinating here is how these precautions really escalate based on the specific germ's travel plans, essentially.
Precisely. It's a calibrated system designed to break that chain of infection at the right point. And it really underscores that simple hand hygiene, whether soap and water or alcohol gel when appropriate, is always the #1 fundamental defense against spreading germs.
Always #1. How do we assess if someone has an infection? What are the key signs?
Common signs include fever, or sometimes even hypothermia, especially in the elderly or very young. Chills, fatigue, malaise. Local signs at the site of infection might be redness, swelling, warmth, pain. Lab-wise, an elevated white blood cell count is a classic indicator. You might see pus or drainage.
Anything specific for older adults?
Yes. Critically, especially in older adults, a sudden change in mental status, confusion, agitation, lethargy can be the first and sometimes the only sign of an infection brewing. Always take that seriously and watch vital signs. Increased heart rate, increased respiratory rate, and especially decreased blood pressure can be warning signs of sepsis, a life-threatening systemic infection.
Okay, change in mental status in the elderly is a big red flag. Let's talk specific bugs. MRSA.
Methicillin-resistant Staphylococcus aureus. It's a type of staph bacteria resistant to common antibiotics. Often presents as skin infections, boils, abscesses, but can cause serious pneumonia or sepsis. Transmission is via contact, so contact precautions. Gown, gloves, maybe dedicated equipment. Prevention relies heavily on hand hygiene and environmental cleaning. Vancomycin is often the treatment.
And C, diff again, Clostridioides difficile.
Causes significant watery diarrhea, often after antibiotic use disrupts the normal gut flora. Also fever, abdominal pain. Transmission is via spores, fecal-oral route, remember, soap and water for hands, bleach for surfaces. Treatment is typically oral vancomycin.
Influenza, the flu.
Sudden onset of fever, chills, sore throat, cough, body aches, spread by droplets, so droplet precautions, surgical mask within 6 feet. Best prevention, the annual flu vaccine.
Tuberculosis, TB.
Caused by Mycobacterium tuberculosis. Primarily affects the lungs. Classic symptoms are persistent cough, often lasting weeks, night sweats, fever, weight loss, and sometimes hemoptysis, coughing up blood.
Coughing blood, okay.
Spread via airborne route, so airborne precautions. N95, negative pressure room. Patient wears a surgical mask when transported. Testing involves skin tests like the MAN2 PPD, blood tests like quantiferon, chest x-ray, and sputum cultures to confirm. Treatment requires long-term combination antibiotic therapy, often called RIP therapy.
And COVID-19.
Transmission primarily via droplets, but also airborne, especially during aerosol-generated procedures like intubation. So routine care often involves droplet plus contact precautions. But for AGPs, it's airborne precautions plus eye protection N95, gown, gloves, face shield, or goggles. Prevention strategies include vaccination, hand hygiene, and proper PPE use.
Okay, quite a range. Now, sometimes the body's own defense system goes a bit haywire, right? Leading to allergies or autoimmune conditions. Let's unpack hypersensitivity reactions, maybe using that acid mnemonic.
Sure. Hypersensitivity is basically an overactive or inappropriate immune response. Type I is the immediate anaphylactic reaction. It's IgE-mediated, often triggered by allergens like foods, peanuts, shellfish, insect stings, latex, medications.
For scary kind.
Yeah, rapid onset. Think airway swelling, wheezing, difficulty breathing, hives, low blood pressure, fast heart rate. It's a true emergency. Airway first. Intervention involves epinephrine IM, stat, oxygen, food fluids, antihistamines, corticosteroids follow. Patient education is key. Avoid triggers, always carry an EpiPen, wear a medical ID bracelet.
Okay, type 1 is anaphylaxis allergy, type 2.
Type 2 is cytotoxic. Here, antibodies, IgG or IgM, mistakenly target the body's own cells. The classic example is a mismatched blood transfusion reaction, leading to hemolysis destruction of red blood cells. Symptoms include fever, chills, back pain, hypotension. Also seen in some autoimmune conditions like autoimmune hemolytic anemia,
Type 3.
immune complex mediated. Antibodies bind to antigens, forming complexes that get deposited in tissues, triggering inflammation. This is the mechanism behind diseases like systemic lupus erythematosus, SLE, or rheumatoid arthritis, and serum sickness. You see joint pain, rash, fever,
And type 4.
delayed hypersensitivity. This one is mediated by T cells, not antibodies, and the reaction takes time to develop, usually 48 to 72 hours after exposure. Think of the reaction to a TB skin test, poison ivy, or contact dermatitis from things like nickel or latex. A delayed type, different from the immediate type I latex allergy. Symptoms are typically local: redness, swelling, induration, blistering, itching.
ACID. Anaphylactic, cytotoxic, immune complex, delayed, helpful. Let's touch on lupus, SLE.
Systemic lupus erythematosus, a chronic autoimmune disease where the immune system attacks various tissues, joints, skin, kidneys, blood cells, brain, heart, lungs. Key signs often include that characteristic butterfly-shaped rash across the face, malar rash, extreme photosensitivity.
Sensitivity to sun.
Very much so. Also joint pain, fatigue, fever, and often kidney involvement, which can manifest as protein in the urine. Patient education focuses on avoiding sun exposure, use high SPF sunscreen, wear protective clothing balancing rest and activity, and being vigilant for infection, as both the disease and its treatments can suppress the immune system.
Makes sense. And the EpiPen for type I reactions?
Epinephrine autoinjector. It's for emergency treatment of anaphylaxis. You administer it by firmly injecting into the outer thigh. It can go right through clothing. Hold it in place for about 3 to 10 seconds, depending on the device instructions. Critically, call 911 or emergency services immediately after use, even if the person feels better. A second dose might be needed if symptoms don't improve or return.
Call 911 after every use. Got it. Storage.
Room temperature, away from direct light and heat. Check expiration dates regularly.
Okay. What about general safety for immunocompromised patients, people with HIV/AIDS, on chemo, organ transplant recipients, maybe those with lupus on immunosuppressants?
Infection prevention is paramount for them. Number 1, meticulous hand hygiene. Avoid crowds and people who are obviously sick. Avoid raw or undercooked foods, no rare meat, raw eggs, unpasteurized dairy. Critically, no live vaccines for severely immunocompromised individuals. Maintain good skin integrity, practice good oral hygiene.
And at home.
Disinfect frequently touched surfaces. Monitor temperature closely and report any fever, usually defined as over 100.4 degrees F or 38 degrees C, immediately to their healthcare provider. Early detection of infection is key.
Let's briefly touch on HIV and AIDS.
Human immunodeficiency virus. It attacks the immune system, specifically CD4 T cells. Progression typically goes through stages. Stage 1 is acute infection, often flu-like symptoms, CD4 count still above 500. Stage 2 is chronic or asymptomatic, CD4 count between 200 and 499. Stage 3 is AIDS-acquired immunodeficiency syndrome, defined by a CD4 count below 200, or the presence of an AIDS-defining opportunistic illness.
How is it transmitted?
Through specific bodily fluids. Blood, semen, pre-seminal fluid, rectal fluids, vaginal fluids, breast milk. Not spread through casual contact like hugging, sharing utensils, or toilet seats.
Important distinction. Prevention.
Safe sex practices, condoms. Pre-exposure prophylaxis, PRP, for those at high risk. Post-exposure prophylaxis, PEP, after potential exposure. Not sharing needles. Regular HIV testing and prenatal care, including ART, to prevent mother-to-child transmission.
And preventing complications in those living with HIV.
The absolute cornerstone is adherence to antiretroviral therapy, ART. These medications suppress the virus, allowing the immune system to recover. Monitoring CD4 count and viral load is crucial. Preventing and promptly treating opportunistic infections is also vital. For example, prophylaxis with Bactrim to prevent pneumocystis pneumonia, PCP, once the CD4 count drops below a certain level. So if we connect this to the bigger picture, it's really a testament to the immune system's incredible power, both when it functions correctly to protect us and when it overreacts in hypersensitivity, attacks itself in autoimmunity, or is suppressed, leaving individuals vulnerable. Understanding these mechanisms is absolutely key to protecting not just ourselves, but especially those who are most vulnerable.
Powerful stuff. Okay, finally, let's talk about the body's largest organ, our skin. It's not just a covering. It's our primary barrier, our first line of defense, and often a vital indicator of overall health.
Absolutely.
Yeah.
And one common issue, especially in healthcare settings, is pressure injuries, also known as pressure ulcers or bed sores. They're caused by prolonged pressure, usually over bony prominences like the sacrum, heels, hips.
Where the bone is close to the skin.
Exactly. This pressure cuts off blood flow, leading to tissue damage. Friction and shear, like sliding down a bed, and excessive moisture also contribute significantly. Risk factors include immobility, Poor nutrition, older age, decreased sensory perception, like in diabetic neuropathy, and certain chronic conditions.
Prevention is key, right?
Paramount. Frequent repositioning, typically every 2 hours for bedbound patients, more often for chairbound. Using pressure-relieving surfaces like specialized mattresses or cushions. Keeping the skin clean and dry, using barrier creams if needed for incontinence. Optimizing hydration and nutrition, especially protein intake, and encouraging ambulation or movement as much as possible.
How are they staged? How do we describe them?
Staging is based on the depth of tissue involvement. Stage 1. Intact skin with non-blanchable redness. The skin doesn't turn white when pressed.
Okay, just red won't blanch.
Stage 2. Partial thickness skin loss involving the epidermis and/or dermis. Looks like a shallow open ulcer with a red-pink wound bed, or could be an intact or ruptured blister.
Like a scrape or blister.
Stage 3. Full thickness skin loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. There might be some undermining or tunneling.
Deeper down to the fat.
Stage 4. Full thickness loss with exposed bone, tendon, or muscle. Slough or eschar might be present, but you can see or feel the underlying structures. Osteomyelitis is a risk here.
Very deep, down to bone or muscle. What about unstageable?
Unstageable is when the base of the ulcer is covered by slough, yellow, tan, gray, green, or brown dead tissue, or eschar, tan, brown, or black leathery dead tissue. So you can't actually see how deep it is until that's removed.
Can't see the bottom. And deep tissue injury.
DDPI. This presents as a persistent, non-blanchable, deep red, maroon, or purple area of intact or non-intact skin, or a blood-filled blister. It indicates damage to the underlying soft tissue from pressure or shear. Even though the surface might look okay initially, it can deteriorate rapidly.
Okay, looks like a deep bruise, basically. How do we assess risk?
The Braden scale is commonly used. It assesses factors like sensory perception, moisture activity, mobility, nutrition, and friction shear. Lower scores indicate higher risk.
Braden scale for risk. Got it. What about psoriasis?
Psoriasis is a chronic autoimmune disorder that causes rapid skin cell turnover, leading to thick, silvery gray, scaly plaques, often on elbows, knees, scalp, and trunk. It's not contagious. Flare-ups can be triggered by various things. Stress, illness, skin trauma, Kovner phenomenon, infections like strep throat, cold weather, certain medications. Management involves topical treatments, phototherapy, and sometimes systemic medications.
Okay, autoimmune skin condition. When skin gets injured, like a cut or wound, how does it heal?
Wound healing typically follows 4 overlapping phases. First, hemostasis happens immediately. Blood vessels constrict, platelets aggregate, and a clot forms to stop the bleeding.
Stop the bleeding.
Second, inflammation. Lasts about 1 to 5 days. Vasodilation occurs, bringing white blood cells to the area to clean up debris and bacteria. You see the classic signs: redness, warmth, swelling, pain.
Cleanup crew arrives.
Third, proliferation. Roughly days 4 to 21. New tissue starts forming. Granulation tissue, the beefy red stuff, fills the wound bed. New blood vessels form, angiogenesis. Epithelial cells migrate across the surface to close the wound.
The rebuilding phase.
Fourth, maturation or remodeling can last from 21 days up to a year or more. Collagen is reorganized and remodeled, increasing the tensile strength of the scar tissue. The scar gradually fades and flattens.
Scar formation and strengthening. Okay, let's talk about burns. Different types.
Burns are classified by the cause. Thermal, flame, scalds from hot liquids, contact with hot objects, electrical, chemical, radiation, like sunburn or radiation therapy, friction burns.
How do we assess them?
2 key things: depth and extent. Depth is classified similarly to pressure injuries, but with different terms. Superficial, like first degree, involves only the epidermis. Red, dry, painful, blanches with pressure, like a typical sunburn.
Epidermis only.
Partial thickness, like second degree, involves the epidermis and part of the dermis, often blistered, moist, red, very painful.
Down into the dermis, blisters.
Full thickness, like third and fourth degree, involves the entire epidermis and dermis, potentially extending into subcutaneous fat, muscle, or bone. The area looks dry, leathery, waxy white, dark brown, or charred. Nerve endings are destroyed, so it might be painless in the center, though surrounding areas might hurt.
All layers destroyed, possibly painless. How about extent?
The extent is the percentage of total body surface area of PSA affected. The rule of 9s is a quick way to estimate this in adults. Divides the body into sections representing 9% or multiples of 9%. Critical for calculating fluid resuscitation needs.
Rule of 9s for TBSA. What else do we monitor?
Airway and breathing are paramount, especially with burns to the face, neck, or chest, or if inhalation injury is suspected. Circulation, assessing for shock. Fluid loss is massive in large burns. Signs of infection. Electrolyte imbalances.
What are the major complications?
Hypovolemic shock from the huge fluid shift out of the vessels is the immediate threat. Infection and sepsis are major risks later on. Airway compromise from swelling or inhalation injury. Compartment syndrome in circumferential burns of limbs or the chest. Electrolyte imbalances, often hyperkalemia initially from cell damage, then hypokalemia later as fluid shift. And long-term, contractures from scar tissue restricting movement.
Lots of potential problems. Interventions.
First, stop the burning process. Remove hot or smoldering clothing, cool the burn, briefly avoid hypothermia. Airway management might be needed immediately. Then, aggressive fluid resuscitation is critical, often guided by the Parkland formula. Pain management is essential. Wound care involves cleaning, debridement, removing dead tissue, dressings, often using topical antimicrobials like silver sulfadiazine. And early physical and occupational therapy is vital to prevent contractures and maintain function.
Parkland formula for fluids, silver sulfadiazine for wounds, PT for function. Got it. Lastly, skin cancer.
3 main types we focus on. Basal cell carcinoma, BCC, is the most common but least aggressive. Often looks like a pearly or waxy bump or a flat, flesh-colored or brown scar-like lesion. Rarely metastasizes but can be locally invasive.
Most commonly scary.
Squamous cell carcinoma, SCC, is the second most common. Often appears as a firm red nodule, a flat sore with a scaly crusted surface, or a new sore on an old scar. Has a higher potential to metastasize than BCC, especially if large or neglected.
Scaly red patches can spread.
And melanoma. This is the least common of the 3, but by far the most deadly because it metastasizes readily. Often arises from an existing mole or appears as a new dark spot. Early detection is crucial.
Most deadly. How do we spot melanoma?
Use the ABCDE rule for assessing moles or suspicious lesions. A for asymmetry, one half doesn't match the other. B for border irregularity. Edges are ragged, notched, or blurred. C for color variation. Uneven color, shades of brown, black, tan, sometimes white, red, or blue. D for diameter. Larger than 6 millimeters, about the size of a pencil eraser, although melanomas can be smaller. E for evolving. The mole changes in size, shape, color, elevation, or develops new symptoms like bleeding, itching, or crusting.
ABCDEs. Asymmetry, border, color, diameter, evolving. That's really helpful. So this brings up an important question, doesn't it? Why is the skin often called the mirror of internal health?
It's a great question. Because its condition really can provide vital clues about what's happening deeper within the body. A pressure injury might reflect immobility or poor nutrition. Certain rashes are hallmarks of autoimmune diseases like lupus. Jaundice indicates liver problems. Pallor might mean anemia. Even subtle changes in moles could signal melanoma. Careful assessment of the skin is absolutely paramount because it gives us so many insights into overall systemic health.
Wow. What a journey we've taken today. We've really covered a lot, exploring the body's delicate internal balances of fluids, electrolytes, acid base, the crucial role of external support like IV therapy and vascular access, the rigorous prep and recovery for surgery, the body's vigilant defense against infections, and the incredible protective functions of our skin, our largest organ.
It's been quite the deep dive. So maybe a final thought for you to ponder. The next time you just feel a bit thirsty, or maybe see a tiny bruise forming, or even just watch someone recovering from what seems like a simple medical procedure, try to consider the immense, usually invisible, orchestration happening within the human body. After our chat today, what small change might you notice now that you perhaps never did before, understanding its potentially deeper implications?
That's a great takeaway. We really hope this deep dive has given you a fresh perspective and maybe equipped you with a better foundational understanding of how truly incredible and complex the human body is. Keep exploring, keep learning, and we'll see you on the next deep dive.